Hi there, welcome to this lecture on scanning the abdomens of our feline patients. Perhaps you have had the opportunity to scan some feline patients at this point, and maybe you have noticed some differences already. And as the saying goes, cats are not just small dogs, and therefore there are some considerations and species-specific findings we must be aware of when imaging these patients with ultrasound. So I do typically recommend gabapentin for cats, for cardiac workups in particular, but it may also reduce the need for sedation in abdominal ultrasonographic examinations too, so always worth considering. And with feline patients, you can often get away with a much smaller hair clip patch, as their skin is quite movable, and you can shimmy that clip patch over to the liver or draw it back towards the bladder, for example, too. I hope you remember that probe frequency plays an important role in what you can image and the quality of that image obtained. So higher frequencies, they are employed for imaging superficial structures. Therefore, which transducer may confer superior image resolution in your tiny little superficial cat? A microconvex probe or a linear probe? Yep, the linear probe, it excels here. However, remember the linear probe footprint may actually be the same size as the abdomen of some cats, which may make it challenging to image the liver subcostally, for example, and may feel cumbersome on a small kitten. So this lecture is going to focus on the ultrasonographic appearance of normal feline anatomy observed when scanning. And yes, it is relatively similar to the canine counterpart, but there are some important differences that we need to be aware of. And there's going to be a further discussion on some of the more feline-specific pathologies. Let's begin with the spleen. The spleen can be more challenging to find in cats, and in some cases can be isoechoic to the surrounding fat. The head of the spleen is located caudolaterally to the fundus of the stomach, and it runs along the left lateral wall of the abdomen, typically quite dorsally. It's easily accessible, and an intercostal approach is actually not often needed here. It's uniform in size and shape. Mild undulations may be present along the mesenteric border, where the splenic veins leave the parenchyma, as is quite nicely demonstrated in this image here. And the echo texture is typically slightly more coarse than in dogs. Remember, assessing the size of the spleen is really rather subjective in dogs. However, in cats, there really is far less variability. A cat spleen may be up to about 6 centimetres in length, although typically between 3 and 5 centimetres. However, the length isn't really measured routinely. It's the width that we focus on. And the width may be variable across the spleen at different portions, with the tail perhaps having the most potential to be falsely enlarged. So you want to measure somewhere in the middle, really, possibly a couple of times. One paper indicates that the average splenic height or width or thickness, as we can say, is 0.71 centimetres, with a range of 0.51 to 0.91 centimetres. Several other papers have suggested 1 centimetre as the cutoff for splenomegaly, and more recent papers highlight that up to 1.1 centimetre may be within normal limits. And the feline spleen is less of a blood reservoir than in dogs, so changes in size are more likely to be pathological. Sedation can cause splenomegaly, but far less commonly. ACP, again, as in dogs, was the only drug that statistically significantly increased splenic size and up to double the normal size. Furthermore, Hansen et al. In 2001 report that it's rare for a feline spleen to fold over on itself unless it is indeed enlarged. So measure the height, thickness or width and look for folds. So causes of splenic enlargement without a focal lesion include diffuse malignant infiltration such as lymphoma, histiocytic sarcoma, mast cell tumour, multiple myeloma, but also extramedullary hematopoiesis and lymphoid hyperplasia, as well as a lot of others. So in this 1992 study, splenic disease in 37% of feline patients was caused by primary and metastatic neoplasia. And lymphoid hyperplasia accounted for about 7% of cases of splenomegaly and extramedullary hematopoiesis about 4%. Interestingly, another more recent paper in 2001 suggests a much higher number of feline spleens affected by neoplasia. It suggested 73% of splenic changes in cats are due to neoplasia. We'll have a little look at what those changes might be in a minute. Of these diffuse primary and metastatic splenic neoplasms, mast cell was the most common, then lymphoma or lymphosarcoma, myeloproliferative disease, and then hemangiosarcoma. The spleen is a common site for primary mast cell in cats and is the most common hematopoietic tumour of the spleen. It's most commonly observed in older cats as well. So these ultrasonographic changes are the more common observations occurring with neoplastic splenic infiltration. Diffuse enlargement, an irregular contour, generalized hypoechogenicity, or that very typical honeycomb, leopard spot or mottle pattern that's described. With regards to mast cell tumour specifically, some cases of mast cell present with a smaller hyperechoic spleen, and mast cell infiltration may cause an irregular margination of the spleen, leading to an often more lobulated appearance. With regards to lymphoma, in one study, 83% of cats with lymphoma had an enlarged spleen, but in 32% of them, this was the only change observed with ultrasound. With splenic lymphoma as well, there's more likely to be a fusion in the abdomen and mesenteric lymphadenopathy too. And finally, remember, a normal spleen cannot exclude clinically significant disease. So what else might cause a mottled splenic appearance? If you are used to scanning with a microconvex probe and then start to utilize a linear probe, you're going to notice a difference in the interpretation of echo texture. Higher frequencies conferred with a linear probe can cause the spleen to have a mottled pattern. You get this improved axial resolution and the echo texture is more pronounced. So do get used to using the linear probe on the spleen of a cat and don't overdiagnose infiltrative disease. Furthermore, the mottled pattern can be observed in feline patients with lymphoid hyperplasia, extramedullary hematopoiesis and congestion, and as with dogs, these can appear really rather variable. A very helpful 2018 study addressed the association between the ultrasonographic appearance of the splenic parenchyma and cytology results in feline patients. In this study of 170 cats, 25 patients were described as having a moth-eaten splenic appearance on ultrasound. Of these 25 cats, only 20% had malignant neoplasia confirmed with cytology. That is perhaps less than I would have anticipated, so ultrasound-guided sampling can be very rewarding in those patients with a moth-eaten splenic appearance. Time for a few questions. Firstly, how could this image of a feline spleen be further optimized? Secondly, is the spleen enlarged? And thirdly, what might be causing the dark distal acoustic shadowing on the cranial aspect or the left aspect of the image here? So pause the video now and take a moment to answer these questions and restart the recording when you are ready. Okay, for the first question, with regards to image optimization, I would say perhaps the gain is a little bit high. The image is perhaps slightly overly bright. And I would say that the field of view is too big. I might decrease that field of view to allow the spleen to occupy about 2/3 of my field of view. Is the spleen enlarged? No, it's about the 1 centimetre mark for the width. Seems great. What might be causing the dark distal acoustic shadowing on the cranial aspect of the image? This could be rib, but as we mentioned, realistically in the feline patient, the spleen isn't really subcostal, so probably it's hair artifact. Okay, hope you got some of them right. Moving away from diffuse splenic disease to the focal nodules. In cats, diffuse disease of the spleen occurs more frequently than focal or multifocal nodules or masses, but the opposite is true in dogs. Focal lesions in cats are most commonly due to neoplasia, hyperplasia, or extramedullary hematopoiesis. Interestingly, Bertal et al. In 2018 found that focal splenic lesions greater than 1 centimetre in a feline patient is predictive of malignancy. Most splenic nodules in cats appear isoechoic to hypoechoic relative to the normal splenic parenchyma. With regards to size, well, the 1 centimetre cutoff point may be helpful, but cases of lymphoid hyperplasia or extramedullary hematopoiesis with nodules up to 3 centimetres have actually been reported. Hematomas, they may be larger but typically reduce over time, unlike tumours. Myelolipomas, as in dogs, may occasionally get rather large. So taking samples with ultrasound-guided FNA or FNB with serial monitoring may be beneficial in these cases, assessing for growth over time. This slide is to emphasise the point that 1 centimetre is the cat number for the spleen. A spleen over 1 centimetre in width or height or thickness, however you want to call it, is indicative of splenomegaly, most likely due to infiltrative disease of some description, and a nodule greater than 1 centimetre in width is predictive of malignancy. Again, ultrasound-guided sampling will provide further clarification on the cause. Moving on to the hepatobiliary system. Feline-specific features of the hepatobiliary system include the fact that the feline liver has a coarser echotexture compared to the spleen. Yes, this is true in dogs, but more pronounced in cats. In some normal cats, the liver can appear isoechoic or even hyperechoic to the spleen, and the hepatic portal veins are less conspicuous than in dogs. Is this liver here hyperechoic? So you note the similarity in echogenicity of the liver and spleen here. Is this pathological? It's much harder to say this in cats, as the liver may only be slightly hypoechoic to the splenic parenchyma in normal. Okay, what is this arrow pointing to in the ventral aspect of the cranial abdomen of this feline patient? This is indeed falciform fat, which, as you can appreciate, is far more voluminous in cats than it is in dogs. It can occasionally be challenging to delineate the falciform fat from the hepatic parenchyma. And although the falciform fat typically has a slightly coarser echotexture again than the liver, annoyingly, the liver is very often isoechoic to the falciform fat. So one trick is to watch the patient breathe. Ideally, the liver should move or slide or glide slightly against this falciform fat. Now, as cats often have this copious volume of falciform fat, it may lead to a false impression of hepatomegaly, and radiographs may be helpful here if we are unsure. Regarding hepatic lipidosis, it is the most common liver disorder in cats. Peripheral mobilization of fat exceeding the liver's ability to utilize these fat stores as energy or to redistribute it leads to hepatocyte distension. Cells become filled with fat. And ultrasonographically speaking, this can result in an enlarged hepatic parenchyma, which is diffusely hyperechoic. It can be hyperechoic to the falciform fat, as depicted in this image here. You may have even poorer visibility of the portal markings, and interestingly, beam attenuation can occur. So beam attenuation is where the increased fat causes increased absorption or scattering of the ultrasound waves before they can reach the deeper tissues, leading to a sort of signal dropout in the far field of the image. A paper in 1992 stated that a liver that is hyperechoic to the falciform fat in cats has a greater than 90% sensitivity for detecting hepatic lipidosis. And that is not unhelpful. Regarding cholangiohepatitis, which is arguably the second most common hepatic disease in cats, well, the ultrasound may detect abnormalities, but realistically, the appearance is incredibly variable. The liver can appear normal, hyperechoic or hypoechoic, heterogeneous, nodular or uniform, enlarged or of normal size. So ultrasound-guided sampling can be helpful if we're concerned of cholangiohepatitis. Regarding hepatobiliary tumours in cats, one study determined that 65% of hepatobiliary tumours in their feline patients were benign. This does not hold true, obviously, for our canine patients, as they are more commonly malignant. In feline patients, primary tumours are more common than metastatic disease. In dogs, metastatic liver disease is more common. Another study suggested that benign hepatic neoplasms are more common in older cats, where malignancy of the liver occurs more commonly in younger patients less than 9 years of age. This is just one study, though. Okay, This is an image of the most common feline hepatic neoplasm. What is it? This is indeed a biliary cyst adenoma, also known as the bile duct adenoma, cholangiocellular adenoma, or cystic cholangioma. And it's a very characteristic lesion in the liver of cats, far more commonly observed in cats than in dogs. And typically it's found in older feline patients. It is the most common primary neoplasm in the cat. It typically appears ultrasonographically like a cluster of cysts, which, although can be variable, always appear as such. These cysts can vary from 1 millimeters to 8 millimeters in size. And if there is a sort of hyperechoic mass observed in the liver with these cystic components, the hyperechoic portion is likely due to two things: fibrous stroma and or distal acoustic enhancement. And they can get very big, over 10 centimetres in certain circumstances. And although they are most often an incidental findings, when biliary cyst adenomas get big, they can cause compression of adjacent structures, asserting a mass effect and becoming clinically significant. Moving on to the biliary system more specifically, diseases of the biliary tract are more common than hepatic disorders in cats. The gallbladder, the wall should be less than 1 millimeter thick, but very often in our feline patients, the gallbladder wall is not actually visualized at all. The cystic ducts and common bile ducts are far more conspicuous and tortuous than in dogs. And the common bile duct can be up to 4 millimeters in diameter with a wall thickness of about 1 millimeter. Ideally, you are going to try and locate the common bile duct in 3 regions. Firstly, following the neck of the gallbladder caudally. Secondly, adjacent to a portion of the portal vein near the hepatic hilus. And again, thirdly, at the level of the major duodenal papilla. With regards to the gallbladder, I very much hope you have all had the chance to witness at least one bilobed or accessory gallbladder. It's a delight. And this anatomical variation is reportedly present in 1 in 8 cats. A bilobed gallbladder can appear as a septum dividing the gallbladder lumen into 2 portions. Another variation is where the gallbladder neck has 2 lumens, which appear kind of like a heart shape, and this is my favourite. And then there's the duplex form, and this appears as 2 separate gallbladders with separate necks and cystic ducts, and it's really quite rare. Question time: is sludge in the gallbladder of a cat concerning? This is interesting. So in cats, gallbladder sludge has been linked to increased total bilirubin and elevated liver enzymes, hepatobiliary disease and cholangitis. However, a very recent paper published at the end of 2025 reported that the ultrasonographic identification of sludge does not reliably predict biliary infection or inflammation. And this retrospective study also stated that feline patients with gallbladder sludge were not more likely to have elevated liver enzymes or total bilirubin, which I found rather interesting, rather controversial. Okay, regarding cholecystitis, a gallbladder wall thickness of greater than 1 millimeters is predictive of disease. Although a normal wall thickness does not rule out mild or chronic inflammation, diffuse wall thickening has been reported in 55% of cats with hepatobiliary disease. And this may present ultrasonographically as a diffusely thickened hyperechoic wall, as depicted in the image here, or potentially a sort of double rim effect. Other ultrasonographic findings in case of cholecystitis may include hyperechoic dependent sludge or sediment, small volumes of effusion adjacent to the gallbladder, and a positive ultrasonographic Murphy sign where you apply pressure and it incites some discomfort or pain. And we must mention cholangitis, or the cholangitis cholangiohepatitis complex, as the liver is often involved too. And there's 2 forms that are described based upon the more prevalent cell type: acute neutrophilic cholangitis or the more chronic lymphocytic form. In the acute form, in many cases, ultrasonography of the liver and biliary tract is normal. If changes are present, they may include gallbladder wall thickening, common bile duct dilation or thickening, biliary sludge, cololiths, choledocholiths, but these can happen for other reasons too. Lymphocytic cases are more likely to have a rather abnormal set of findings on ultrasound due to the chronic nature of the inflammation. Biliary fibrosis may be present, irregular bile ducts with often dilations and strictures. The appearance is very variable and really rather bizarre looking. Okay, let's discuss the gastrointestinal tract. The stomach of feline patients has far less gas, thus limiting this artifact for us. The stomach has a very classic wagon wheel appearance when it is empty. Interestingly and importantly, cats very often have a much more prominent submucosal layer. It appears more hyperechoic, and this is due to fat infiltration. And the pylorus is typically located more within the midline of the patient, not as superficially as dogs, slightly more in the deep. So compare the submucosa of the stomach of this feline and this canine patient. The submucosa of the feline patient can be far more prominent than that of the dog. When you see gas in the stomach of a cat excessively with ultrasound, do a radiograph. There is usually a marked problem. I don't know if anyone can see what the problem is here. This poor patient was involved in a car accident and had a diaphragmatic hernia and a herniation of a lung lobe through the esophageal hiatus. Gastric neoplasia is not overly common in feline patients, but lymphoma is, of course, the most common cause of this. It can cause a complete loss of wall layering and is often circumferential and hypoechoic. This patient here presented with abdominal effusion that was populated with numerous lymphocytes and a markedly overly conspicuous gastric lymph node too. Regarding the intestines, the duodenum appears much more similar to the jejunum in cats. The mucosal layer is much thinner than in dogs, and although the mucosa is still the thickest segment of the small bowel, it is a little more challenging to discern the duodenum from the jejunum in cats. The duodenum, as I've mentioned, occupies a more midline and central or dorsal location within our feline patients. The jejunum should be fairly well distributed throughout the abdomen in cats. However, in obese patients, these bowel loops may be more clumped together in one region of the abdomen. In the ileum, it's the muscularis and submucosal layers that are the thickest layers, and there is that wagon wheel appearance in cross-section too. And the cat has an iliocecal-colic junction, which may appear a little differently on ultrasound to the canine ileocolic and cecocolic junctions. But before we go any further, please remember that a gastrointestinal tract that appears normal with ultrasound does not exclude clinically significant disease. It's really important to know what normal is to better understand what is abnormal when observing the gastrointestinal tract in our canine and feline patients. So the wall layering of the gastrointestinal tract is the same as in dogs. Here's some small bowel and its lumen, mucosa, submucosa, muscularis and serosa. And when you do have abnormal, you can have focal abnormal and you can have diffuse abnormal. Focal lesions are going to cause an increase in wall thickness with a partial or complete loss of wall layering at that specific point. One study, looking at dogs, I do confess, found that 99% of patients with a focal gastrointestinal tract neoplasm had complete loss of wall layering, where only 11% of inflammatory lesions caused loss of wall layering. Thus, focal lesions within the gastrointestinal tract with partial or complete loss of wall layering are suggestive of neoplasia. Diffuse thickening, particularly of the muscularis circumferentially throughout numerous segments of bowel or the entire bowel, is most commonly due to lymphoma, lymphocytic enteritis more commonly in dog, and eosinophilic enteritis more commonly in cat. As we're talking about cats, lymphoma was going to be a feature of this lecture. Gastrointestinal tract lymphoma is the most common form of lymphoma in cats, and this obliteration in wall layering may be partial or complete, and the intestinal wall segment may be thickened too. As we've mentioned, inflammation occasionally causes loss of wall layering, but far less commonly. The diffuse form of lymphoma in cats is more common, And these diffuse changes affect the muscularis, and this can cause the muscularis layer to equal the mucosal layer in thickness. That's pretty thick. Alternatively, an increased thickness of the muscularis may be determined by comparing it to the submucosal layer, as they should be roughly of equal thickness. So a muscularis layer that is greater than 1 to 1.5 times thicker than the submucosa is concerning for infiltrative disease. If, while scanning, a short segment of bowel is stumbled upon that has a thickened muscularis layer, always ensure that it is not the ileum. Track it both directions and identify if it meets the colon, confirming it is indeed the ileum. If it's not the ileum, it's concerning for diffuse thickening, and then consider pathology. Diffuse intestinal changes in cats are more commonly associated with lymphoma than IBD, but IBD presentations like this are more common. A brilliant paper by Dagno et al. In 2014 assessed ultrasonographic thickening of the muscularis layer in feline IBD and lymphoma patients, and they determined that with both diseases, the muscularis layer was really the only layer affected by an increase in thickness, and that it may be up to 2 times the thickness of healthy feline patients. In both healthy and diseased patients, the other bowel layers remain unchanged. They reported that both diseases can occur simultaneously, and that this is not uncommon. It's been hypothesized that chronic inflammation is an inciting event to lymphoma, and another study showed that 60% of cats with lymphoma of the gastrointestinal tract had a previous history of clinical signs that could be attributable to IBD. Perhaps there is a continuum of disease from inflammation to neoplasia, and this is why they appear so similarly ultrasonographically. Additionally, cats with lymphoma are typically older than those with the inflammatory disease too. Interestingly, they reported that IBD is more prevalent in the duodenum and lymphoma in the distal jejunum. However, full thickness biopsies are going to be required for a definitive diagnosis. Moving on, these are images of a 1.5-year-old female entire domestic shorthair that was 1 week postpartum. She was not able to keep food down and appeared painful on abdominal palpation. An ultrasonographic examination was performed, and what pathology is evident in this patient? Yes, this is indeed an intussusception demonstrated in both transverse and longitudinal views. In cats, the appearance, as you can appreciate, closely resembles dogs. Interestingly, there is a bimodal age distribution with occurrence in patients less than 1 year of age and greater than 9 years of age. Intussusceptions are usually jejuno-jejunal in the cat, with lymphoma and IBD being the most common underlying causes in our older patients. Now let's take a look at the pancreas. In cats, the duodenum is far more central and dorsal, as we've mentioned, than in canine patients, and it can be challenging to discern, and thus the markers for the pancreas and the pancreatic location are often harder to identify. The body of the pancreas lies midline and in close proximity to the portal vein. Unlike in dogs, the distal portion of the right limb appears smaller and sort of hooked-like. Because in cats, it's the left limb of the pancreas that's more easily identified than the right. It's much, much larger. Remember, it's the right limb, of course, in the pancreas that is more conspicuous in dogs. As cats age, the pancreatic duct often becomes wider and more tortuous. In humans, the pancreatic duct becomes wider due to atrophy of the pancreatic parenchyma. Perhaps this could be the same for cats too. I hope you can appreciate this. This duct can really appear rather conspicuous in older patients, and as the duct is going to have a slower flow than a vessel, it should not have colour Doppler signal. A very clinically important anatomical difference between cats and dogs occurs at the ampulla of Vater in the major duodenal papilla. In most cats, the common bile duct and pancreatic duct merge prior to entry to the major duodenal papilla at the ampulla of Vater. In a minority of cats, there is a separate opening into the duodenum, like a dog. In about 20% of cats, there's also an accessory duct that drains into the minor papilla of the duodenum. So the major duodenal papilla is about 3 centimetres from the pyloric outflow, and the minor duodenal papilla is about 2 centimetres further on distally through the duodenum from the major duodenal papilla. In feline patients, even with clinically significant disease, the pancreas can look entirely normal, and the literature is highly variable, with the reported sensitivity of detecting abnormalities of the pancreas between 11% and 80%. Huge variation. More recently, a paper has suggested severe pancreatitis can be detected about 80% of the time, with milder cases with ultrasound being detected around 60% of the time. So pancreatitis is the most common exocrine pathology of the feline pancreas, but an underlying cause is rarely identified and the condition is often termed idiopathic. Siamese cats are perhaps overrepresented and any age can be affected. Typically in cats, the body and the left limb are more commonly inflamed, unlike in dogs where it is the right limb most frequently affected. Pancreatitis in the cat is considered more commonly chronic in nature, although acute cases do occur, and both are considered to be underdiagnosed in our feline patients. In cats, the ultrasonographic features of acute pancreatitis are similar to dogs, but typically slightly more subtle. However, when the pancreas is enlarged, it can be over twice the width of the spleen. Hyperechoic peripancreatic fat may be quite a sensitive marker in cats, as several studies have demonstrated this. And one study noted that this feature was identified in 68% of cats that had an elevated serum FPLI. If there is a clinical concern for acute pancreatitis in a feline patient and there is a normal ultrasonographic examination, a repeat scan 2 to 4 days later may allow time for ultrasonographic changes to appear. In chronic pancreatitis, the fibrosis prevails above inflammation, and this can occur due to repeated episodes of inflammation perhaps, and the parenchyma is typically hyperechoic or heterogeneous. However, some papers have suggested chronic pancreatitis may present ultrasonographically as a hypoechoic pancreatic parenchyma too. Very helpful. As you can appreciate, there is an overlap in the ultrasonographic appearance of both chronic and acute disease. So does the image on the left or does the image on the right more likely depict acute pancreatitis? Yes, I would suggest the image on the left. You have the hypoechoic pancreatic parenchyma with hyperechoic peripancreatic fat. So ultrasound is the imaging modality of choice for pancreatitis, but please do remember there is a poor correlation between ultrasonographic appearance, disease severity, and duration, acute versus chronic. In feline patients with pancreatitis, cholangitis, cholangiohepatitis, IBD, hepatic lipidosis are detected concurrently 50 to 56% of the time. So always examine the liver, the pancreas and small bowel adjacently. It is the common portion of the major pancreatic duct and common bile duct that predispose our feline patients to triaditis. Triaditis is a condition of cats of which the etiology is often poorly understood. It can be caused, at least in part, by infectious agents, autoimmune disorders, and physical components such as the shorter small intestinal tract in cats, the higher bacterial load that's often present, and, as just mentioned, the anatomy, the common opening of the major pancreatic duct and common bile duct. And it may also occur, of course, secondary to systemic bacteremia. So ultrasonographic findings of triaditis include changes in the biliary tree and the liver, changes in the intestines, and changes that are defined or described in the pancreas. Now, regarding the urogenital systems. Most importantly in cats, both kidneys are relatively mobile and may be visualized adjacently to one another in lateral recumbent ultrasonographic examinations. As they are caudal to the ribs, an intercostal approach is really rarely necessary. They are typically rounder than the canine kidneys. They are less elongated or oval shaped. As with canine patients, the size, shape and internal architecture should be evaluated and the left and right kidneys compared. Cat kidneys are fairly standard in size, unlike in dogs. The right kidney may be a little longer. It is recommended as well to measure both the left and right kidneys, and they should measure between 30 and 43 millimetres. A kidney greater than 45 millimetres is generally considered enlarged in a feline patient. Female cats have slightly smaller kidneys than males, and although the literature is variable, intact cats generally have slightly larger kidneys. Interestingly, in cats, the echogenicity of the kidneys is highly variable. A hyperechoic renal cortex is a rather common finding in cats. Fat can accumulate in the cytoplasm of the proximal renal tubules located in the cortex, and this can cause this hyperechoic appearance. And this is going to increase the corticomedullary definition. These kidneys tend to be larger than the kidneys without fat deposition. And this has been linked to neuter status and age, but not body weight, interestingly. It can be a normal finding in older male cats or castrated male cats or pregnant female cats that do not have evidence of renal dysfunction. So this hyperechoic renal cortex can really appear quite marked and appear much, much brighter than the adjacent hepatic parenchyma. So pathological causes of a diffusely hyperechoic renal cortex include lymphoma, nephritis, amyloidosis, other neoplasias, chronic kidney disease, acute kidney disease, ethylene glycol toxicity, Lilly toxicity. But remember, a bright kidney, a bright renal cortex can just be a normal finding in cats. So cats often pack fat into the renal sinus, and this can make this renal pelvis or renal sinus really rather hyperechoic, and this is particularly prevalent in obese cats. And it's important not to mistake this for inflammation of the renal sinus or renal pelvis, as it really can look quite bright. Regarding pyelectasia in cats, in normal patients with normal renal function, normal renal pelvis dilation can be up to 1.6 millimetres. In patients with normal renal function that have diuresis, so IV fluid therapy, certain medications, etc., up to 2.3 millimetres in dilation can be considered normal. With regards to renal disease is a common health problem of our feline patients, and ultrasound is of course more sensitive and specific than radiography for assessment of renal disease in cats and dogs. However, ultrasonographic variations in the renal parenchyma are not overly specific. Ultrasound lacks specificity. There are often several differential diagnoses for any given ultrasonographic presentation, so always take into consideration the history, the signalment, blood work, your analysis, and of course your imaging. And remember, a normal renal appearance with ultrasound does not rule out clinically significant disease. Chronic kidney disease is a prevalent disorder amongst cats, with 62.5% prevalence in cats over the age of 10, according to one recent study. Ultrasonographic features of CKD are similar to dogs and include a reduced renal volume, irregular margination of the kidneys, increased cortical echogenicity, not overly helpful, decreased corticomedullary definition, cortex medullary ratio that's been shifted, pyelectasia, cortical cysts, and mineralization. So renal length is routinely assessed in ultrasound. However, it is less useful than the corticomedullary ratio as an indicator of CKD in feline patients. So a study in 2020 showed that the cortex medulla ratio had a better correlation with disease severity than renal length. And they suggest that it could be useful to monitor renal cortical thickness as disease progresses. As disease progresses, the cortex is going to become thinner. So 66% of cats with CKD have been demonstrated to have pyelectasia. So like dogs, this is a more prevalent feature of chronic kidney disease ultrasonographically. With regards to mineralization, one study showed 61% of cats with CKD have a form of nephrocalcinosis. On the opposite end of the spectrum, renomegaly in cats is a kidney that is over 45 millimetres in length, obtained in a long axis image. And causes of renomegaly include acute kidney injury, lymphoma, infection, so FIP, obstruction, cysts, or loss of contralateral renal function. And lymphoma is typically a diffuse renal neoplasm and is the most common neoplasm of the feline kidneys, and very often it's present bilaterally. Ultrasonographic features include that rhinomegaly, a hyperechoic cortex, pilectasia, irregular margination, and an interesting feature is the subcapsular hypoechoic rim effect. And this subcapsular rim, or crescent, is often a thick fluid rich in lymphocytes in lymphoma patients. And it's rather specific for lymphoma. However, it may be present in other diseases such as FIP, which we are going to briefly mention. The effusive form is absolutely the easier of the two forms to detect and diagnose with the aid of ultrasound, abdominocentesis, and fluid analysis. The non-effusive form causes an array of changes within the patient, but regarding the kidneys specifically, it can cause that rhinomegaly, irregular renal margin, diffuse or focally increased echogenicity of the renal cortex, increased echogenicity of the renal medulla, and of course that subcapsular hypoechoic rim. It is a differential for lymphoma. Polycystic kidney disease, well, it's really rather relatively self-explanatory. It's an inherited autosomal dominant disease causing the progressive development of renal cystic lesions. It's primarily associated with Persian cats, but also British Shorthairs, Himalayans, ragdolls, and tends to be subclinical until the feline patients hit middle age. Polycystic kidney disease affects one or both kidneys, causing cysts in the cortex and the medulla. And these cysts are a variety of sizes, ranging from 1 millimetre all the way up to 20 millimetres. In one study, medullary rim sign and nephroliths were also noted in patients with polycystic kidney disease on ultrasound. As sonographers, we can scan the kidneys of patients from 7 weeks with a good machine and a high-frequency transducer to identify these cysts. However, waiting until the patient is 10 months of age has been demonstrated to have 100% repeatability in renal cyst identification. Furthermore, it's important to check the liver specifically, but the pancreas and uterus too for additional cystic lesions. Now, let's take a moment to answer a few short questions, true or false. Firstly, the feline kidney is approximately 30 to 43 millimetres. The answer is indeed true. It would be ideal to clip the patient's hair to obtain a good image quality. True. It can be confusing to assess which kidney is which in the cat. Absolutely true. Ultrasound is a very specific tool for detecting the cause of diffuse renal disease. Unfortunately not. High frequencies deliver high resolution superficial images at a penetration trade-off. True or false? The answer is indeed true. FIP can cause a subcapsular hypoechoic rim effect in the kidneys. Absolutely, and it's our differential for lymphoma. Renal lymphoma always presents as a solitary mass lesion in the kidneys. False, it's typically diffuse. Kidneys greater than 45 millimetres are considered enlarged in the average cat. True. A hyperechoic renal pelvis is always a pathological finding in feline patients. Don't get caught out on that one. And finally, renal pelvis dilation can be normal up to 1.6 millimetres in the cat. True. Now, for a brief look at the urinary bladder. Sediment in cats. Is this always a pathological finding in our feline patients? The answer is indeed no. It's not uncommon to diagnose lipid droplets within the urine of cats. And ultrasonographically, this appears like sediment, so hyperechoic swirling dependent sediment. Fat droplets are a common occurrence in the urinary bladder of cats. Regarding the prostate, it's not an overtly obvious organ in cats, unlike in dogs. It can be incredibly challenging to observe with ultrasound, and in fact, some of the literature around the subject suggests you cannot actually see the prostate in a cat, with it only being identified histologically, and I kind of hold true with that as well. However, there is prostatic carcinoma. It is a rare occurrence in cats, but it is still recommended as part of your routine systematic scan to check the neck of the urinary bladder and proximal urethra. And the final hurdle, the small parts. The adrenal glands in cats are typically easier to find than in dogs. They're located slightly cranially to the kidneys in most instances, and they are typically bean or oval shaped. Sometimes you can see a sort of two-layered appearance that may be observed, and if it is, more commonly it appears, as in the schematic here, with a hypoechoic rim and an internal hyperechoic portion, although the other way around is possible too. Mineralization of the feline adrenal glands is considered an incidental finding, where in dogs it's commonly associated with neoplasia. So this mineralization is not uncommon, and it's found in about 30% of cats when scanning the adrenal glands. And of course, there are very few clinically relevant disorders of the adrenal glands in cats, but it's still worth trying to find the adrenal glands and being proud when you do. So cats may get Cushing's, the majority of which will also have diabetes. Hyperaldosteronism or Conn syndrome is the most common adrenal disorder of the cat, characterized by systemic hypertension and sodium retention, typically in older feline patients. In the primary form, it is typically caused by an adrenal neoplasm, and adrenal tumours are typically greater than 2 centimetres in the short axis when measured with ultrasound. So it is important to assess both adrenal glands if you are concerned. And finally, some studies have indicated hyperthyroidism may cause adrenomegaly too. This 2008 paper looked at how often abdominal lymph nodes were identified with ultrasound in a healthy cat. They found that the medial iliac lymph nodes were identified 100% of the time, the jejunal lymph nodes 90%, hepatic lymph nodes 70%, and the ileocecal or colic nodes about 50% of the time. The other lymph nodes were less visible, and they concluded that ultrasonography is a valuable tool for the identification and evaluation of most abdominal lymph nodes in the cat. So that concludes this lecture. If you have any questions, please don't hesitate to reach out. And as always, it is time to practice. So do try this month to scan some feline patients. Attempt to locate particularly the left limb of the feline pancreas. Always measure the spleen multiple times. Can you find the adrenal glands? And compare the liver echogenicity to the falciform fat. Happy scanning!